Just started it. We're going to take another second and let everyone join the webinar, and then we'll begin. All righty. Well, hello, everybody. Thank you for joining us tonight. We have Dr. Christopher Pokabla here to present on shoulder instability. Before we begin, I'd like to ask that you submit your questions via Zoom throughout the presentation, and at the conclusion of his presentation, I'll read these off and Dr. Pokabla will answer them. A quick introduction of OrthoSouth. We offer comprehensive orthopedic care across multiple clinic locations in the Mid-South region and have surgery centers in both Germantown, Tennessee and South Haven, Mississippi. Now to introduce Dr. Pokabla. Dr. Pokabla is a board-certified, fellowship-trained orthopedic surgeon specializing in sports medicine, shoulder surgery, and shoulder replacement, He received his medical degree from Northeastern Ohio University College of Medicine. He completed his orthopedic surgery residency at Ohio State University in Columbus, Ohio, and then he completed a fellowship in sports medicine and shoulder surgery at Mississippi Sports Medicine and Orthopedic Center in Jackson, Mississippi, and the Tulane Institute of Sports Medicine in New Orleans, Louisiana. During his fellowship training, Dr. Pokabla served as the team physician for Tulane University and is currently the associate master instructor for AANA shoulder courses at the Orthopedic Learning Center in Chicago, Illinois. Additionally, because apparently Dr. Pokabla doesn't like to sleep, he is the team physician for Arlington High School and works with the physician assistant students at Christian Brothers University. Then to ice the cake, Dr. Pokabla is also the current president of the Memphis Medical Society. So without further ado, take it away, Dr. Pokabla.
Well, Savannah, thank you for the kind introduction, and I want to welcome all of you tonight. Thank you for attending this webinar presented for OrthoSouth. We have every specialty in orthopedics covered, not just shoulder. I want to emphasize that to all of you. So whether it's foot and ankle or hip or knee or back problems, we've got you covered. So without further ado, let's start talking tonight about shoulder instability, one of my favorite topics. So starting out, let's talk about the shoulder joint. It's the most mobile joint in your body. And so this allows you a ton of range of motion. You can lift your arm, you can rotate it, you can reach over your head, and it turns in almost every direction. However, this predisposes the joint to instability. So let's first talk about stability, and that's the ability to keep a joint balanced or centered so that it's concentrically reduced. And stability is maintained through a complex interplay of both bone and soft tissue. So we have bone, we have ligaments and tendons, and then the soft tissues also include your muscles, which are dynamic constraints that hold the shoulder in the socket. The shoulder joint is minimally constrained, and that means you can get this wide range of motion. And it's really a balancing act. Some people refer to it as a ball on a seal's nose. And that's because the socket, which is called the glenoid, is very shallow. So you're only getting about 25 to 30% of the humeral head, which is the ball, in contact with the socket, which is the glenoid. Shoulder instability, which we're talking about tonight, is when the head of the humerus, which is the upper bone, comes out of the socket, and that's called a dislocation. And once this occurs, it's vulnerable to repeat episodes. Once the shoulder slips out of place repeatedly, this is what we call shoulder instability. So let's look at the anatomy. This is a nice little cartoon, and it shows three of the bones that make up the shoulder: the humerus, which is the upper arm bone, your scapula, which is your shoulder blade, and that also contains the glenoid you can see in the middle of the screen, which is the socket. And then, of course, your collarbone, which is also called the clavicle. You can also see some of the tendons you have your biceps tendon and your rotator cuff tendon, which also go across the shoulder joint and also help to stabilize it. The glenoid labrum is also an important part of the shoulder socket, and it extends the glenoid, the socket, the surface of it, and it increases the width and the depth. It also acts as an anchor for your capsule and ligaments, and you can see the red arrow there. That shows you a picture of what the labrum looks like, and we'll get to see that arthroscopically a little bit later on. Here's a picture also showing you the ligaments that stabilize the shoulder, and they do this more towards the extremes of motion. So when your shoulder is forced at the end range of its motion, and each one of these ligaments you can see here has an anatomic position in the capsule, and that is also where it functions. So the degree and the direction of load put on the shoulder correlate to those ligaments and the injury pattern that develops. So what causes instability? Well, a single traumatic event can cause a deficiency of one of those specific anatomic regions that we just looked at, but also repetitive microtrauma and even voluntary instability results in plastic deformation and attenuation of those stabilizing structures. There's two types of instability. There's subluxation, and this is when the shoulder is partially out of the socket. You can see on the upper right side of the screen, that's a partial instability, whereas a complete dislocation, which is on the lower cartoon, is when the ball comes all the way out of the socket. That's called a dislocation. And when you have a shoulder dislocation, typically the glenoid, which is the socket, and the ligaments are injured, and the labrum, which we talked about earlier, may also tear. And this is called a Bankart lesion. This was named after a doctor. He put his name on it. So let's look at some of the other pathologies that you can have. We talked about the Bankart lesion. You can also have a reverse Bankart lesion. That's when a shoulder dislocates posteriorly as opposed to anteriorly. You can also injure the capsule. You can have a Hill-Sachs lesion, which you can see here, which is an impression defect in the humeral head, and I'll show you that later. And then you can also have hyperlaxity. We'll go over all of these. So let's start with the most common one. This is anterior instability. So when the shoulder comes out the front, and it's separation of the anterior inferior labral complex from the glenoid rim. This is a short little video, and you can see here, this is a Bankart tear. So on the right side is the socket, and then on the left side, you can see where the tear is located. This is a little freer elevator type device that I use, and I'm probing that tear. You can see how it's separated or torn off of the socket there. And this is the most common lesion that you see. This is the one that most orthopedic surgeons are fixing when we're treating patients with instability. You can also have a posterior or reverse Bankart. And this doesn't look the same. They typically aren't as pulled off. You can see it's a little bit detached, but not completely detached like you see with a traditional Bankart lesion. But it's still a disruption of the ligaments and the labrum, but now in the posterior direction. And you can see the ball there and the socket quite easily on this video. You can also have a capsular lesion where essentially instead of a Bankart, you can see here on the left where it's pulled off of the humeral side. And so this is a rupture of the ligament on the other side of the joint, not on the socket, but coming off of the ball. And you can see the ligament right there is pulled off downwards. And you can also see capsular lesions in patients that have congenital collagen disorders, such as Ehlers-Danlos syndrome. Hill-Sachs lesions are also seen, and this we saw earlier on the CT scan. This is an impression fracture of the posterior lateral humeral head. I'm going to play this video, and you can see this is a big Hill-Sachs lesion right there. The shoulder's dislocated. Now it's back in the socket. It's out of the socket, and there it's back in. And that's a big defect that allows the head to come out of the socket like that. This other little video shows it as well. You can see here, there's the defect as the shoulder comes out of the socket. So you're seeing instability right now. You're seeing the shoulder come out as the arthroscope, which is a little camera, is viewing during surgery. And this basically causes wear. It wears away the bone, and you can see you no longer have that normal sphericity. You've lost it here. Hyperlax patients also are predisposed to instability. And these are some patients that have never had a dislocation. Their ligaments are loose. And when this increased looseness is their normal anatomy, it's called hyperlaxity. So it's harder for them to maintain shoulder stability. And we see that oftentimes in athletes that do repetitive overhead motions, such as swimming, tennis, and volleyball players. So what are symptoms? Well, we know repeated shoulder dislocations, also repeated instances of the shoulder giving out. So a lot of patients come into me and they say, it's not dislocating, but it feels like doc, it's given out on me. Oftentimes a sensation that it's slipping, and even just pain caused by a shoulder injury. Sometimes they don't feel like it's dislocated, but it's just simply painful. So when should you see an orthopedic surgeon? Well, if you experience a traumatic dislocation or subluxation of your shoulder, that's a really good reason to see your orthopedic surgeon. If you're having recurrent instability episodes, that's another very good reason. And in fact, any traumatic injury to your shoulder that causes significant pain, weakness, or loss of motion. So when you come to see your orthopedic surgeon, they're going to take a history. They're going to look at your age, your occupation, your hand dominance, how you injured the shoulder, and then, of course, any associated medical problems you may have. And frequently, the history will tell your surgeon the pathology of the instability, just listening to your patient. So if I have a young patient and they're playing football, a contact sport, and they have an anteriorly directed blow to the posterior shoulder, their arm is in a position of abduction and external rotation, I'm going to think about traumatic anterior instability. Patients that have seizures, electrical shock, or chronic alcohol abuse, you have a high suspicion for posterior dislocations. And then when you have patients that come in and say, hey, I can pop my shoulder out, and there's no history of trauma, we think about multidirectional. So this means more than one direction of instability. We'll also perform a shoulder exam. It's a very systematic exam. I inspect the shoulder. I'm going to palpate, which means push on certain areas to see where there's tenderness. We always test their range of motion. Stability tests are very important. I'm going to show you those. And then their neurovascular exam, whether their nerves and arteries are working. And then I like to examine the contralateral, the other shoulder, so that I can compare it and see what's normal. One of the stability tests that I use is called a load and shift test. And so here's a patient that I'm actually performing surgery on. And so they're asleep, but you can see here, the shoulder is going to come in and out of the joint here. Can you guys all see the shoulder? I'm loading it and then I'm shifting it and it's just dislocating out of the joint. So it's coming in and out there, which obviously would be much more painful if you were awake. There are some other things I want to do. We talked about ligamentous laxity, so I want to look to see if they have a sulcus sign. And you can see in the top right, this is a patient that has a very significant sulcus sign. And this is indicative of ligamentous laxity. This is another patient at the bottom, the little video showing the hand, and you can see thumb to forearm. Some people can do this rather easily, and this is another sign of ligamentous laxity. We're always going to obtain x-rays, and these two x-rays on the right side both show fracture dislocations of shoulder. So you can see the ball is no longer in the socket. I don't know if this pointer works or not, but you can see the ball is now over here. It is not in the socket. Same thing here. Here's your socket, and the ball is outside. And these x-rays will help show us a kind of a screening tool, whether the shoulder is dislocated or not, and any associated fractures or arthritis. A CAT scan you've heard of is computed tomography, and this is best for studying bone. And there's several indications for this, but essentially what I'm looking for are smaller fractures, glenoid rim fractures, which you see here on the right. This is a small chip fracture. If you were to look at the glenoid, which is the socket we talked about, it's supposed to look like a golf tee. And you notice part of the golf tee is ripped off here. And this CAT scan shows that really well. You can also use a CAT scan if an MRI is contraindicated in some patients. MRI is probably the best imaging modality that I use to look at soft tissues. This is an example of an MRI showing you a Bankart tear, which we looked at earlier, where you're having a separation of the labrum and ligamentous structures from the anterior glenoid. So you can see in the back here, the posterior labrum is attached. But if you look up front where the yellow circle is, the anterior labrum is pulled off. These are just two other MRI images showing what's called a bony Bankart fracture, where not only is the ligament pulled off, but part of the bone is fractured as well. And you can see these two circles show the areas of pathology. And interestingly, if you look on this one, there's also a Hill-Sachs lesion, which we talked about earlier, that impression fracture of the humeral head. So now let's get into treatment. There's several non-surgical treatments that can be utilized. Activity modification, that may mean changing your lifestyle. So avoiding these activities that aggravate your symptoms. Non-steroidal anti-inflammatory drugs can be used to reduce pain and swelling. We're talking about ibuprofen, naproxen, and aspirin. Remember, when you take these, take them with food. And if you have any GI upset, you need to discontinue them. Physical therapy is excellent and helps many patients strengthen the shoulder muscles and also work on getting control to increase that stability. And oftentimes you can do that with home exercises as well. So talking about traumatic dislocations, a lot of patients ask me how I treat these, and typically it's temporary immobilization. So I'm going to put them in a sling, and then I'm going to work on physical therapy for their rotator cuff and the other scapular muscles to strengthen them. And covering football, which this time of year is our favorite pastime for many of us, many patients have a dislocation during the season. And a lot of the parents want to know, can my son get back to football? And there's actually studies that have looked at this. And what we found is there's a high percentage that can actually return. This is one study that showed about 80% were able to get back after about 2 weeks. And I think that's important information because there's so many kids that sustain this type of injury. Interestingly, a large percentage of them went on to have recurrent instability episodes. You can see in this one study about 40% had recurrent episodes. So I think that counseling is very important, that we talk to parents when their children are playing these sports. Patient education to me is huge. So patients younger than 25 who are treated non-surgically have a significant increased risk of recurrent instability or dislocations. And we know that it's even a higher rate if they're playing contact sports like rugby or football. Non-surgical treatment is often considered for patients that have lower physical demands, the elderly, if they have significant medical comorbidities, and then you have some patients that have uncontrolled seizure disorders, and so they need to get those under control before we think about surgery. So surgery is offered for patients with repeated dislocations to repair the torn or stretched ligaments so that the ligaments can hold the shoulder in place. And there's two types of surgery that are typically performed, and there's various iterations, but essentially they're arthroscopic techniques, which is making small little holes. And then there's open techniques, and they have different indications to some degree. So arthroscopic surgery is minimally invasive, and it's used to repair the soft tissues. You use a tiny camera, and you're performing surgery with the small instruments like you saw previously. This is a same day or outpatient procedure, and it has really good results. Arthroscopic Bankart repair, which we looked at previously, patients have excellent range of motion, and they have proven long-term results. So let's look at a video. This is a 2-minute video that I made for you guys. This is going through the entire surgery in 2 minutes. It typically takes me about an hour.
Look at that.
But this is the exam, and you can see this patient's shoulder easily dislocates here. So it's back in, and now it's out.
A little bit of a anterior inferior, but you can see there's like a little sulcus here. See that? Back in, out. He almost like jumped.
So you can really see this patient easily comes out. Now we're looking through the tiny camera. You can see the injury right here easily. You can see how it's ripped off the glenoid. The ligaments are torn off, and that's the normal on the right side. So now I'm using a little instrument to free it up, just like I was in that other video previously. And I've sped this up about 4 times so we can get through it quickly because I don't want anyone going to sleep. But you could see how the ligament's severely torn. And so I'm freeing it up to try and get it back to go into the place that it's supposed to be. And we use little sutures. You can see right here, I'm passing the sutures through the ligament and through the labrum. And this little curved passing device, you can see we're pulling it back, and you can see how it's pulling that suture through the injured structure so that we can tie it back down to its normal anatomic position. And so see how I'm pulling it up, it's tensioning it here. And you can see the humeral head. And here's another suture that we're going to tie down. Again, pulling the ligament back up and then tying it down. Here's another pass with the curved needle. And again, we're doing this all through the arthroscope, these small instruments and a tiny camera. So now I'm pulling the ligament back, and there's the final product. You can see a nice bumper of tissue. The ligament's pulled back nicely to the glenoid rim. And this is a patient who's going to have a nice stable shoulder. So some patients are not candidates for this arthroscopic procedure, and some require an open surgical procedure. This is where you make an incision and perform the surgery under direct visualization. And so you have to ask, when do we consider this? And the primary reason is bony deficiency. So when they have lost enough bone that we feel like the arthroscopic technique may not adequately address that bone loss. Although there are some techniques I've actually started doing that involve arthroscopic bony stabilization, but that's a talk for another day. But it's typically indicated when you have over 20% glenoid bone loss. And there's actually some studies that say it may be less than that. But bone deficiency is the primary indication for these open stabilization procedures. And so this is a nice little drawing here on the right. And what you can see is that if you lose a certain amount of bone, the likelihood of you dislocating increases dramatically. So you lose this bone that's anterior inferior with a red arrow, and this creates a mismatch that's worsened than we already know, because we talked about earlier that there's only about 25% of the humeral head in contact with the glenoid. Well, now you're making it worse. So there's less force required for a dislocation event because you're taking some of the bone away. You're taking the socket away. And the procedure that I typically perform is called a Latarjet procedure. Its indications typically include chronic bone loss with recurrent instability and failed arthroscopic repairs. And this is where you transfer part of the scapula called the coracoid. So it's in the same incision, but you transfer it into that defect. And this bony block restores part of the glenoid bony arc. And you can see here, this is the bone block that I put in the front of the glenoid here, and I use 2 screws to stabilize it, and it basically increases that articular bony arc so that you now have more bone than you did previously before the surgery. And these are some x-rays of one of my patients where I performed this Latarjet procedure, and you could see the bone graft is here, and it's kind of holding that humeral head centered on the glenoid here, which is the socket. So after surgery, your shoulder is going to be immobilized temporarily with a sling. And once that sling is removed, you're going to begin exercises to rehabilitate your shoulder with your physical therapist. These exercises help with range of motion, your strengthening, and they're going to prevent scarring as the ligaments heal. And eventually you're going to expand your rehab program and get you back to your normal activities and even sports participation. And I'll typically wait about 6 months if I'm doing an arthroscopic Bankart repair before I'll allow patients back to contact or collision sports. So in summary, shoulder instability occurs when the shoulder is dislocated or subluxed. There are several pathologies associated with instability. The most common is a Bankart lesion. We have both non-surgical and surgical treatment options available for our patients. And rehabilitation is essential. So you're going to work with your physical therapist to get you back to the activities that you enjoy. Thank you very much for attending.
All right, thank you, Dr. Pokabla. If anyone has any questions, please submit them now. And I will say I was emailed several questions, but they are very detailed. So Dr. Pokabla, I think it would be better for me to pass these on to you via email.
Sure.
But I will say that was an excellent presentation and I thoroughly enjoyed the videos and whatnot. So thank you so much.
You're welcome.
We'll take one more second for any questions. Alrighty, well, I will drop my email in the chat. So if anyone would like to email me a question after the presentation, I'll pass it on to Dr. Pokabla. All right, it's in there. We will have this presentation on YouTube and all of our social media outlets within the next day or two. So thank you all so much for attending, and thank you again, Dr. Pokabla.
Thank you very much. Have a great night.
Have a good night.
Bye.